1/4 of India's women have a body mass index of less than a standard 18 kilograms per meter square, while 1/4 on the other hand are overweight. 53.1% of women aged 15 to 49 years are also anemic, show data from National Family Health Survey 4. Undernourished girls and women have a greater probability of giving birth to underweight babies, perpetuating intergenerational malnutrition. The country ranks 102 out of 119 countries in the 2019 Global Hunger Index. To address this challenge, a healthy food system that is the one with inclusive outcomes for people and the planet will be crucial. To achieve this, we will need to transform how we are producing and consuming our food. This shift needs to be informed by a collective understanding of the current challenges, guided by an evidence-based common vision and collective solution spaces for effective actions. Today's event is an effort to bring collaboration between policymakers, academia, business, and civil society to build consensus and enlarge our common understanding of how each stakeholder can take action now and together create transformative pathways. With this, we are delighted to have been joined by an esteemed panel of speakers today representing different national and international organizations to enlighten us on this pertinent issue. This session is being chaired by Shri C.K. Mishra, former Secretary, Ministry of Health and Family Welfare, Ministry of Environment, Forest and Climate Change, Government of India. It is indeed an honor for me to introduce Dr. Ajay Mathur, Director General, the Energy and Resources Institute, to deliver the welcome address for today's session. Dr. Mathur is also a member of the Prime Minister's Council on Climate Change. He was Director General of the Bureau of Energy Efficiency in the Government of India from 2006 till February 2016. He has been a key Indian climate change negotiator and was also the Indian spokesman at the 2015 climate negotiations at Paris. He's a global leader on technological approaches to address climate change, and recently he has joined the global group of industrial, financial, and think tank leaders to co-chair an energy transmission commission which will suggest ways for companies and countries to move towards climate-friendly energy futures. Sir, it has always been an honor being mentored by you at Ledeven College, and our association goes long back. It is my privilege to invite you to deliver the welcome address for today's important event. Thank you, sir.
Thank you very much, Poojaji. It's an honor to be here with you, and particularly in this panel discussion, which is being chaired by Shri C.K. Mishra. Shri C.K. Mishra's background, both in environment and health, and particularly his ability to bring together diverse range of stakeholders and diverse range of issues into a solution-based program is something that has always impressed me and many others. I'm also delighted that we have with us Dr. Lakshmaiah, Dr. Ranjan Sankar, Alok Ranjan, Purnima Menon, and of course my colleague Meena Sehgal. It's also a pleasure to welcome the many participants who have joined this webinar. You know, it is particularly important because we need to see how we move ahead. On the one hand, we are the first in the world as far as milk production, as far as production of pulses is concerned. We are second in the world as far as fruit production is concerned. We are third in the total cereal production, in egg production. We are second in population. Yet, 4 out of 10 children in this country are underweight. 6 out of 10 are anemic. We have a nutrition status which is poorer than many of our neighboring countries. I would take you back to the late 1960s when we had a problem of providing sheer food, sheer calories to the people. The Green Revolution changed that. It needed a lot of hard work, it needed a lot of focused attention, but today we are in a completely different space as far as food security is concerned. Some years ago, my colleagues were working with the tribal people outside Bombay and found that calorific inputs were adequate, but nutritional inputs were completely inadequate. This is something that we face today. And my view is that just as a green revolution brought in food security, there is no reason why a new revolution, we can give it any color name that you want, blue, green, whatever. There's no reason why a new revolution cannot bring in nutritional security. We have the tools that it takes. What we need is, do we have the nutrition? Yes, we do. In the tribal belt in Mumbai that I spoke about, nutrition was locally available through plants that were growing there. What it needed was a program through which local women harvested that nutrition, converted it into actually khakras, which they sold to their neighbors, they put it over their dal chawal. Meena is trying to do something similar in Mukteshwar, working on nutritional supplements made from local sources and creating local production centers. And hopefully, if this is successful, its adoption by the ICDS program and so on. We also are looking at the issue of keeping food or food products safer and more preserved in the food chain. To me, cold storages are important. When I look at the number of cold storages in the country, I find that only 1/3 are in rural areas, 2/3 are in peri-urban areas. Why? It was surprising, but not so surprising, that this is dependent on electricity supply. Because places where electricity supply is poor, you need to make it function, you need diesel gensets, and that makes it expensive. With renewable energy technologies, whether biomass or solar, it is now possible to have cost-effective cold storage or cold chains across the country. My view is that the creation of opportunities, livelihood opportunities around nutrition and the creation of cold chains can together address this issue. But I'm getting ahead of myself. We have an eminent panel. I again welcome them. I look forward to ideas on how we can weave a tapestry of innovations. We can do it in one taluka here, one village there, but what we need is to capture the, 250,000 panchayats that we have to enable this kind of a nutritional input program to become as successful as the food security program of yesterday. Again, welcome you all, and I look forward to this discussion. Mishra ji, it's all yours.
Thank you so much, sir. After sir, such a encouraging welcome address. We really look forward to take this platform. We are honored to have Mr. C.K. Mishra to chair this webinar. Shri C.K. Mishra with the Indian Administrative Service in 1980. He was secretary in the Ministry of Environment, Forest and Climate Change. Prior to this, secretary in charge of Ministry of Health and Family Welfare, and also held the additional charge of Ministry of Ayush. He was additional secretary, action director, National Health Mission, led one who led at one point of time the largest health globally. In more than 30 years of public service, C.K. Mishra has served as an administrator, policymaker, and public strategist, holding a wide range of assignments in the field of health, education, industry, and power. Shri C.K. Mishra is recognized for his significant contributions to improving the Indian public health landscape. Sir, humbly I invite you to present a keynote address on nutrition status and response strategies for India. Thank you, sir.
I hope I'm audible. Uh, you see, Dr. Mathur has already touched upon some of the issues which I really wanted to bring forth in this little time that I have. But we, all of us together, are looking at experts who would follow to really give us the guidance, really take us forward on where we should move as far as nutrition in India is concerned. Our friends, we are meeting in extremely extraordinary times. And in this pandemic period, a lot of talk has been there of mortality, morbidity, but somehow or other, the fact that a good nutrition population could have helped immunity levels have not come forward to the extent that they should have. I think this is the ideal time when we start this discussion, have a debate on this, and take it forward, not in the traditional sense, but in the sense of actually making everybody healthy. Let me begin by saying that as far as nutrition is concerned, we've had a lot of debate. We have a lot of programs, and every time the country faces a challenge, you have a Abhiyaan going, and we have a Abhiyaan for this also. And to be very honest, India has made lots of gains as well. It's not what it was a few years back. I mean, people would quote figures of stunting from 48% to 38% and things like that. That is definitely an improvement. But it's not about numbers. It's not about the data. It's about general well-being that we should really be concerned. And I think we need to connect nutrition to the general well-being of human being. And somehow the strategies that we've been adopting all along have been a reaction to an event or reaction to a situation. Some long-term thinking has come in, but then as I go along, I'll try and explain that we need to move from our present way of thinking into something that is different. We as a country continue to bear a very high burden, and Poojaji gave you some of the figures on that. Let me look at it in terms of the situation today from three lenses. The first lens that I would look at is the MCH lens, the maternal child health lens, which India has been focused on for all this while. If you look at that, close to 69% children under 5 deaths is attributable to this. If you look at the maternal side, 51% of the women of reproductive age and close to 50% of pregnant women are anemic, are malnourished, and 25% certainly come in the category of undernourished. So we have a situation on our hand where there is a huge population. It's not about availability of food. It's about what they eat, and it's about how they perceive food. It's not about a policy of pushing food and ensuring that nobody dies of hunger. That's not the situation in India. It's about the right kind of food, the right kind of people to increase their levels of nutrition. The second lens that I would like to look at on all this is, let us move away a little from this old path that we have taken of maternal child health and look at the overall health and wellness. When you look at the overall health and wellness, you find that the vulnerables, irrespective of whether they are women, men, child, whoever, are actually in a corner today as far as nutrition is concerned. And we need to somehow or other look at how to, get nourishment to them in a better way. The third lens I would like to use today is the lens of micronutrients and anemia. That is another critical factor. One third, globally, there are about 2 billion people who suffer from micronutrient vitamin deficiency. One third of that population is supposed to be in India. So there is, if you look at the entire kaleidoscope, there is what I would like to call some kind of a hidden hunger somewhere which we need to address. Now, for example, I just mentioned the issue of anemia. Let's look at anemia for a minute. Anemia, according to the NHFS 4 data, 58% children under 5, 36% of the children are underweight, 53% women in the reproductive age, which really in India we say 15 to 49. It's a very long span, but that's what we normally take. And it's not just women, 23% of the men in the same group are also anemic. Therefore, what we do know for sure is that we have a problem at hand which we need to handle. And currently, if you look at the current situation, as I said in the beginning, the pandemic has drawn our attention to certain very critical things. But what it has also done is that it has affected all 4 aspects of food security. It has affected availability, it has restricted access, it has disturbed stability and utilization. So you really are looking at a situation, as Lancet says, that 1.2 million under 5 deaths are likely to happen. That's kind of projection that people are making. And if you look at the food security and nutrition report, 130 million, they say, will get pushed into chronic hunger. Irrespective of whether these figures are correct or not, the fact remains that a sizable section of the population needs attention and therefore needs a response which is likely to control this. And this is particularly for the vulnerable segment that it is critical. So how do we strategize? Let us come straight to that point. My own view, and I would love to learn from the experts. Each of these webinars for me is a huge learning experience. I would like to learn from them. But for me, there are 3 critical elements to the strategy that we need to formulate. First is, whatever strategy we follow must be practical. Second, they must be deliverable. And third, and most critical, they must be acceptable to the people for whom we are making that strategy. And I also feel that nutrition is not just about science. Mere science may not help us fight the cause of nutrition. I think another critical element that we need to add to this whole nutrition program in India is culture. The culture of the people, the understanding of the people also forms a very, very vital part. And so the issue that comes to my mind is that there are 2 kinds of things happening which do not match each other. On the one side, you have the nutritional requirement of the vulnerable group, and on the other side, you have the policy prescription by government and other forces, which defines malnutrition in its own way and addresses nutrition in its own way, and both do not seem to match. We seem to be over-dependent on events and tackling events. We are so far lacking sustainability. I'll give you one example. One of the critical elements that feeds into nutrition is the program under the National Health Mission for severely malnourished children. The child is brought to the facility, kept there for a number of days. When his weight grows, he's sent back. Little do we realize that what we gave him in the hospital is not available at home. So we've gotten onto a food pattern which he will not be able to follow for the rest of his life. So I think right from the beginning, we need to ensure that the food that he can afford, and I mean, in the food patterns all over the country, nutrition is not an issue. You really need to look at what is nutritious enough to be given. So we need to work on local issues in a very strong way. And this brings me to the point that, all our responses are more medical in nature. We need to look at a holistic food strategy, and this food strategy must be region wise and cluster wise. One of the major concerns, if you look at all our strategies, including the Poshan Abhiyaan and everything, major concern has been prevent deaths from malnutrition, prevent deaths from the severity of deficiency of micronutrients, etc. Why aren't we starting a good debate that it's not just about preventing death, it's about making a person physically better. It's about creating better immunity in the person. It's about creating a healthy being. So I think we need to move towards this slowly. And quality of life, and as it is often said by the Prime Minister and others, that ease of living. So quality of life is something that we need to focus on. And if you, as an example, look at our response, for example, to the issue of deficiency of micronutrient and anemia. We have been trying this idea of food fortification for a very long time now, and still not closed the chapter. And we have 22 states and 5 union territories which have started participating in it. But they're all looking at standard safety net programs like the ICDS or the PDS. I think this idea needs to grow beyond that. I mean, voluntary food fortification has begun in some 5 states or so only, and most of them are busy doing pilots. There are known facts for which I don't think we really need to get into a pilot mode for everything. If you look at the private sector, I'm told about 110 odd companies have now started fortifying, which is oil, milk, wheat, flour, salt, rice. But this is not available to everyone at an affordable price and not available everywhere in the market. So while we struggle with the pilots, we are not able to scale. And one of the reasons I feel we are not able to put it to scale is that as we have been in, let's say, the Swachh Bharat Abhiyaan or other things, we have not been aggressive enough when it comes to nutrition. We've been cautious, we've been very medical in our approach, and we have only reacted to events. Another aspect is that's often debated is who's our target? And if you look at the history of nutrition, we've been talking about stunted children, wasted children, undernourished children. We've been talking about pregnant and lactating women. But I think for a future of this country, the ideal target is 253 million adolescents that we have here. That is the number that we need to really treat so that when they become mothers or when they have children, or a child is born, they are not malnourished. So let us look at the adolescent population as a focus of planning and strategy, and not just pregnant lactating women and children or very weak men. If you start at that level, perhaps you will not need to do very much at a later level. And we must look at the possibilities of convergence of program across ministries, across sectors. What I would advocate really is that we need to adopt a food system approach. In policy making, we need to get this approach of food system into our thought process. We've been debating for long whether we should, through ICDS, be giving pre-cooked meal or cooked meal. I mean, that's not the point. Every 100 kilometers in India, the food habits and culture changes. If the food habit and culture is changing, why don't we stick to traditional food habits and find out the best thing, like Dr. Mathur was mentioning about Bombay and he was mentioning about some others. So there are these local available nutrients which we need to tap instead of trying a centralized package which we think are nutrients which will help them. If you want to do that, you must have a very good quality program with sustainability in order to sustain that for a long, long time, which we don't have. So let us look at culture, let us look at the eating habits, let us look at the ethos, and I would strongly advocate let children eat what their grandparents did or great grandparents did. Let us promote that in a more scientific, organized way, which means that it should be accessible to them and affordable to them. Other issue that we must look at, and I'm sure many of the panelists will be talking about it, is integration of agriculture with health and nutrition. There have been three different pillars not meeting very often. Health, nutrition, and agriculture must converge at some point and ensure that affordable nutrients are accessible and available to people. Let us look at this entire system of nutrients in the context of the food we consume and not just an additionality. For supplementary strategy, of course, you have multi-micron supplementation, you have large-scale fortification of food, and all these things will come. But they, as I said, they're still not cost effective. Therefore, our best bet is to go back to our culture, go back to our eating habits and find the best solution. I think if we have a strategy woven around that, which is completely decentralized, depending on the locality and depending on the eating and food habits, I think we might see some success. There is no reason to discontinue with what you are doing. But there's a strong case for also adding what I just mentioned we need to add. So I'm very happy to be here with all of you and happy to share my views. But I think we have a very eminent panel waiting who will inform us of many of the things that we should be doing in this country. And I think we'll take those learnings soon. So thank you very much for hearing. Thank you.
Thank you so much for such an insightful keynote address. It further instills confidence in us at Lady Abhiyaan College for being on the right path. Coming from academia as a part of Lady Abhiyaan College, it is a pleasure to share that this premier institution is the flagship for contributing towards achieving nutrition status sustainably. Lady Abhiyaan College is a training partner under Food Safety Training and Certification Initiative of SSAI, Project Institute under Ministry of Skill and Entrepreneurship Development. It houses National Center of Excellence and Advanced Research on Diets, which is providing technical support for maternal health division, Ministry of Health and Family Welfare Government of India, and supported by UNICEF. It has Roshni, Center for Women Collectives-led Social Action, which works as a technical and knowledge management support ANLM. It is a skill development center in collaboration with industry and capacity and skill initiative. May I request mute all speakers to mute? There is an echo sound coming. It's a skill development center in collaboration with food industry and capacity and skill initiative, FIXI, formed under the aegis of NSDC and FICCI. These centers have been instrumental in developing guidelines on strengthening maternal nutrition services for antenatal care at community level, guiding consensus-driven policy needs on maternal nutrition, acting as an apex laboratory for development and standardization of local food products, designing and conduct of capacity building programs, developing entrepreneurs, empowering women collectives and equipping them to lead social actions on food, nutrition, health, and WASH. We strive to build a cadre of prospective professionals, practitioners for paving way forward for creating healthy, sustainable, livable, and inclusive environment. I truly believe that this event will have much to take away from. Before bringing forth our eminent speakers for the day, can I request to switch on video for a picture? And Dr. Mathur, Mr. Mishra, please join us for a group picture.
We don't have an option. We are here.
Sir, it's a pleasure. I'll request the panelists to switch on the video mode.
Dr. Purnima Menon and Professor Lakshmaya, could I request you? I see. Yes, thank you.
Are we through? I think the organizers have taken the picture. Meenaji, is it done?
I think it is. Poojaji, let's go ahead.
Today we are delighted to have with us eminent speakers working in this field to deliberate on status, challenges, and solutions. We have Dr. Alok Ranjan, Country Lead Nutrition, Bill and Melinda Gates Foundation, Ms. Meena Sehgal, Senior Fellow, the Energy and Resources Institute, Dr. Lakshmaya, Head, Public Health, National Institute of Nutrition, Dr. Ranjan Sankar, Director, the Indian Nutrition Initiative, Tata Trust, Dr. Purnima Menon, Senior Research Fellow, International Food Policy Research Institute, Shri S. Vijay Kumar, Distinguished Fellow, TERI, Lead, Food and Land Use Coalition, India, former Secretary, Ministry of Rural Development. I'll request our panelists to take 15 minutes or so for presentation so that we have enough time for deliberations and question and answer session. We have our first speaker, Dr. Alok Ranjan, Country Lead, Nutrition, Bill and Melinda Gates Foundation for India, Bangladesh, Indonesia, and South Asia. Prior to joining the foundation, Dr. Ranjan was nutrition specialist for UNICEF in Bihar. Early on, the nutrition specialist for UNICEF in Uttar Pradesh. He has over 15 years of experience in the area of public health and nutrition across research, IIM Ahmedabad, polio, WHO, NPSP, routine immunization, child health, maternal health, emergency health and nutrition at UNICEF. Dr. Ranjan, I would invite you to give your presentation on need to address nutrition through the system strengthening approach. Please join.
Thank you, Poojaji. Can you hear me and can you see my slides?
Yes, we can, Alok.
Thank you so much. So first of all, big thanks to the Energy and Resource Institute and the Food and Land Use Coalition for inviting me on this discussion. Really honored to be here with all the eminent panelists as well as with Mishra sir giving the keynote address. I also wish everyone health and safety in this time of the pandemic that's ongoing right now. Uh, Thank you for giving me the topic of addressing the nutrition through the system strengthening approach, and I really believe that it is key to a lot of things that Mishra sir was highlighting towards in his keynote address. Um, I feel that India is one country where we have almost majority of the evidence-based policies in place for nutrition that a global community agrees upon. Uh, there would be very limited countries in the world which would have a set of HR where for every 1,000 population you have not one Anganwadi worker, not one ASHA, not one Anganwadi helper, but also A&M going there once every month. So we are fortunate to have that sort of policies, the HR, and also if you combine all the funding across various nutrition specific and sensitive interventions as they're called out, it's immense, phenomenal in terms of how much India spends in various aspects of programming, which can have an impact on nutrition. Probably what is missing is to take all these evidence which has been there in policies and how further policy improvements can be done to add on the component of adequate and proper implementation at scale with quality. I think India has had many examples, even if you take the example around polio, routine immunization, or many of the other programs, we have seen how this systems have been able to mobilize to address various components. And I think for nutrition, which has somebody who I believe as a mentor for me defines nutrition as something which has been in the past voiceless. Mostly kids less than 2 years who are the ones that are the face of undernutrition. They parents also don't take them to the health facilities or a doctor for addressing undernutrition. They are taken there if there is a fever or there is a diarrhea or any complication. And many a times treatment is also done for those components and not for the underlying factors that led to that. The second way he describes it is undernutrition. Undernutrition is an invisible aspect, as Mr. Mathur mentioned that around say 40% of our kids under 5 are undernourished. It's a norm. Every second child is undernourished, so it doesn't stand out that this child is undernourished or is stunted or has a height less than what it should be. It becomes a kind of a norm. Third way he described it was that nutrition is an orphan. It is something which is multi-sectoral. It is across food systems, health systems, social protection system, community systems, wash systems. Everyone contributes to that. And in a way, no one is accountable for it. And globally, I think it falls between the cracks of multiple systems around all these systems that we are talking about. And fourth big aspect is it remains mostly unmeasured. Yeah, we do measure stunting level, wasting level, undernutrition, anemia level once every 3 years. We don't measure what goes on in terms of making these programs improve, whether the household contacts are happening, whether the counseling for the behavior change, which Mishra sir highlighted towards, are those happening? Are the quality of the distribution of say take-home rations and PDS supplies, are those happening continuously and with the quality that should happen? So we don't really measure what is going below that stunting, wasting, and anemia level. We just know those numbers, and we need to unpack what's below that. So with these four things, it's being voiceless, invisible, orphan, and unmeasured in the past. I think in India with Poshan Abhiyaan, there has been a good traction, good momentum where it has a voice. It is no more invisible. I think there is a lot of ownership around driving it. So it's not an orphan. And I do feel like with the sort of measurements and data-driven thinking that Niti is pushing, it doesn't remain unmeasured at this point of time. So we seem to be on the right path. And I think with the systems approach is what would be very, very key and critical going ahead. And this is one of my favorite quotes where Bill, during his last visit to India, in one of the interviews, he said, if I had one wish for India, it would be for India to get rid of malnutrition. Even at the global level, there was a question about if you have a magic wand, what would you want to do, and he said find solution for malnutrition. So that's so high in terms of the priorities from our co-chair side as well. And what India has been driving with Poshan Abhiyaan is something exactly that we need to start building upon and advancing the nutrition profile of India's programs. When we talk about nutrition and the determinants around nutrition and what does it lead to, it's not something which needs a lot of research at this point of time. I think it was way back in 2013 Lancet where this framework was shared, and a lot of momentum on the nutrition investment as well as the programming kind of kick-started and skyrocketed with this framework coming through. And if you look here on the left side, the nutrition specific interventions, there is hardly any aspect of this which our national programs are not focusing or prioritizing. Also, if you look at on the left hand side, when you look at all the aspects around, say, agriculture, social safety net programs, women's empowerment, water sanitation, family planning, all these are very high in terms of the priorities of the government around improving and strengthening those components. So it's a place where it's all about getting these done so that it makes a better impact in terms of the nutrition outcome, and not kind of searching for that magic bullet, because unfortunately for nutrition there is no one magic bullet. It's something where we have to work on almost all the components so that that mother-child diet who passes through that 1,000 days, and absolutely Mishra sir talked about the adolescents, with all these interventions needs to come, and convergence need to happen at that household level. Convergence doesn't would not make an impact if it happens at the national level, at the state level, at the district level, between ministries, between departments and all. If those doesn't converge at the household where this life cycle happens, we would not see any impact. And unfortunately, a lot of convergence discussion doesn't reach that household level discourse, I would say. So this is where I feel that the framework is available to us. Framework is very complex in terms of nutrition doesn't get addressed, undernutrition doesn't get addressed only by working on nutrition specific. So many nutrition sensitive have to deliver, and that's when it'll happen. But I don't think that in nutrition we have really taken a systems lens. We have the health system strengthening framework that WHO has given, which has been part of what most of the countries globally and most of the partners, development partners and others working in the health sector have been focusing on. And they have been focusing and talking about this for decades now, and they have been driving the MNCH and other program through that lens. Have we done that for the nutrition as well? Right now, there is Jan Andolan, which is a key part of the Poshan Abhiyaan. Do we measure what has been the impact of that Jan Andolan? What has been the intensity of that Jan Andolan activities? Whether are we sustaining that intensity around the year, or it is just during a few months in a year and then it fizzles down? In terms of the service delivery, have we ensured the supply? Have we ensured the availability of HR in place who will be driving these components? Have we looked at the goal setting that there are, of course, Poshan Abhiyaan has goals to be achieved at the end of Poshan Abhiyaan. But what does it mean in terms of breaking it down for states and districts in terms of, and are there mechanisms of holding them accountable? Are there governance mechanism which is kind of looking at, and it has to be contextualized to every district, every state, because even in a district, for example, we work quite a lot in UP and Bihar. And in terms of when you look at that, there is a whole plethora of districts performing very well and districts which are very laggard in the process. So it cannot be one size fits all. Financing, if you look at the spend of the Poshan Abhiyaan over last few years, there is so much more needed and desired to be done in terms of the financing. And there is still so much unutilized from the Poshan Abhiyaan's budget itself year on year. And how can we improve that? How can we address that? Because I don't think in India it's more about having, yeah, of course, it will be great to have more money for nutrition. But what would be very relevant is, can we get more nutrition from the money which is already there for nutrition? I think that is the big missing piece, and that is what we need to drive that component. We need to focus on those components. Human resource. Have we been just focusing on the frontline worker and burdening them, building their capacity to pass on the message, to deliver services? Or have we also strengthened the system above that? Because a frontline worker would only do what her or his supervisor holds his or him to accountable for. If they hold him accountable, tumne wazan kiya, have you weighed the child or have you distributed the ration? If they don't hold them accountable for, did you counsel? Did you support? Did you negotiate with them what is available in their house? Like Mishra sir was saying, that it's about availability of food, but how does it change in terms of the practice? So if the house, it is available in the household, have you spent time counseling them that this is what needs to be fed to the child after the child crosses 6 months? Have we looked at all those things? And the two things on the sides which I say here is, it cannot just be through one system. The health system, ICDS system, social protection system, food systems, communities, we have SHG groups, PRI members, everyone, and nobody has to go on saying this is what you have to do in nutrition. They just ensure delivering what they are supposed to do, and everything adds up to a more holistic impact subsequently. And this has to be implementation across national, state, district, villages, and community level. The one more slide which I would like to really bring across is, majority of nutrition focused discourse in the past has been in the last two rows here. It is counseling the family, and they're also unfortunately focusing only on mother, as if it is mother's job to do that, and service provider, building their capacity, them to deliver everything. We have really not focused in terms of what will it take the entire system to do that. Are we really building the capacity for managers from national to supervisory level? Have we inculcated the supportive supervision or mentoring mechanisms there? We are running behind the increasing coverage level, which is very important, but are we looking whether that coverage is with quality? Otherwise, with high coverage, we'll hardly end up having any impact subsequently. Are we using data? There are ample amount of data from NFHS to regular MPR and MIS data available. Are we using those? Are we utilizing those? And of course, financing, HR, supply chain management. Unless we look at these and just focus on frontline worker counseling with the household, that is most critical, very critical. But without the all these components, which is not in her control, but unless we work on those, her ability to deliver is way reduced. And something going back to what Mishra sir talked about is, when the SAM child, severe acute malnourished child, is treated in a facility and sent back to the household, they go back to the same environment, same set of components, which brings the child back to relapse to the same status where the child had been before. So if you enter your office, your room, and the tap is on, you'll close the tap. You will not keep on mopping the floor, because you will then end up mopping the floor till eternity. So I think we need to focus on closing the tap. That is the big missing piece of the nutrition programming, I would say, at the global level. I'm not saying from the national perspective. Global level, a lot of focus has been on closing that, on mopping the floor. We identify the kid, let's identify the kid, let's measure the anthropometry, and let's treat them. This would be a never-ending process. If you want to achieve SDG 3, SDG 2.2, it cannot be done by just mopping the floor. That is very important. We need to take care of those kids who are severe acute malnourished. We need to provide them adequate and quality care. But the big focus has to be, as Mishra has said, focusing on adolescent, focusing on preconception, pregnant women, breastfeeding, complementary feeding, first 2 years of life, along with that, the adolescents and the first 1,000 years. Those are the most critical. And I would finish my presentation with this slide, where I think 2 is equal to 17. It's this I love this, because SDG 2, where nutrition lies, it contributes to better achievement of all the 17 SDGs. And apart from that, I think most of these contribute in a way to achieve better nutrition as well. I would again call out that we cannot just keep on mopping the floor. Let's measure child's nutritional status or mother's nutritional status and keep treating them. There is no end to it. It's like somebody having diabetes, and you don't make that person do the lifestyle changes and just keep giving the anti-diabetic to that person. And it's like this clockwork. What we see at the end is the time with the hour hand and the minutes hand, but what all goes behind in terms of making this happen, there is food system, there is a social protection system, there is health systems, ICDS, communities, engagement, everything comes together in terms of making that impact. And just by solving for one thing cannot make the impact that we want to have. So I strongly believe that nutrition is an investment, and more so in the times of COVID now, as again Mishra sir talked about the immunity and the role it will play more and more going ahead, and an investment that we must all make to give every woman and child the opportunity to survive and thrive. Thank you so much.
Thank you so much, Dr. Ranjan, for such a brilliant perspective of yours. And we simply have to take it forward, this mantra that, let's reorient ourselves to design thinking and empathizing for the real identification of the need rather than mopping the floor and then struggling with it. So I was told that Dr. Ranjan may not stay for the entire program. So I had written in the chat box that if there are questions for Dr. Ranjan, we could just take it now. Else, for other speakers, we'll have Q&A session and we may address the questions. So, Dr. Ranjan, there is a question in the chat box saying that is fortification a short-term strategy to elevate acute levels of malnutrition, or is it a long-term strategy? If the latter, can fortification ever be a substitute for healthy, diverse diets? Would you like to take it?
Sure. I think Dr. Shankar is exactly going to talk about these components, so he will be best placed to. And I think after his session, a lot of these would be already addressed. Let me just give an example from what I was talking about for multiple systems and connecting this with that. If you look at anemia as an area, right? Anemia addressing, when we talk about it, it's not about just IFA, iron folic acid tablet supplementation, right? For the entire population, interventions like fortification as well as diet diversity, what everyone, Mr. Mathur as well as Mishra sir talked about, that diet diversity, local diet, diversification of that, as well as fortification is something which will raise the bar overall. For the ones who need more, who has more requirements during pregnancy, during lactation, during growing phases of adolescence and all that, that's where you have additional interventions like IFA supplementation and others, right? For the phase where there are, we have those who have overflowed and we have the mopping work to be done of this overflow. That's where people are severely anemic. That's where we need therapeutic dosage, and that's where we need components like IV iron and others which are being talked about. So there are multiple things and everything has a role. So for the population, and I think that's where it's not just one solution for everything. And if you see all these multiple systems come together into this entire mechanism. And thanks for giving the questions right now. I'll surely try and rush back to connect on the QA session if possible, and I'll keep you updated on that. Thanks.
Thank you so much. Thank you so much. We have our second speaker, Ms. Meena Sehgal, Senior Fellow, the Energy and Resources Institute, TERI. Could we mute other panelists? Ms. Sehgal is an environmental epidemiologist involved in environmental issues that impact human health. Her expertise is in designing environmental health studies for public health policy recommendations. She leads the Center of Excellence on Vulnerability Assessment and Health Adaptation Planning for Climate Change for the Ministry of Health and Family Welfare, Government of India. Ms. Sehgal would deliberate on nutrition status and its determinants. Ms. Sehgal, please join us.
for introducing me. Okay, I hope you can see my slides, and I'll use a lot of information which has been garnered from the National Family Health Survey and has also been brought out by other speakers. The nutrition status, as we've heard other speakers also say, shows a dismal picture, particularly for India. The underweights are around 35 to 36%. Stunting is also similarly high. Wasting and anemia show a dismal picture too. And it's not only when we compare it across the small region of South Asia, countries like Bangladesh and Sri Lanka show a better scenario. However, the nutrition status has improved over the years. The National Family Health Survey too showed 53% as underweight, and that has come down to nearly 30% in the more recent surveys of 2015, 2016. Prevalence of stunting has also reduced by 10%. Anemia has also come down. If we look at across the country, however, we see a lot of difference. States like Bihar, Jharkhand, Madhya Pradesh are significantly higher than the national average of 38. States like Puducherry, Kerala, Himachal Pradesh are much better and almost half of the national average. They're around 20% in stunting. Same is the story for anemia. High prevalence of poor iron status or anemia seen across Haryana, Jharkhand, Bihar, whereas states of Kerala and Assam, Jammu Kashmir show a much lower prevalence of anemia. Wasting has a similar story to say. Jammu Kashmir and Nagaland, Chandigarh, Manipur are almost close to 5%, whereas states of Gujarat and Karnataka around 25 to 30%. Then we looked at within the states, how were the districts showing these prevalence rates? Here I've projected all the big states and union territories. The stunting country average is the blue line, and the green boxes in these box plots are below the green line, which is a good thing, that they are pulling the average down. So you can see states of Andaman, Goa, Jammu Kashmir, Himachal Pradesh are much lower than significantly lower than the country average. However, some states like Jharkhand, Madhya Pradesh have nearly all their districts are above the country average, and Uttar Pradesh also has nearly all the districts above the country average. Similar is the story for underweight. Bihar and Chhattisgarh, Jharkhand have almost all the districts above the national average. For underweight, Madhya Pradesh and Uttar Pradesh are significantly higher above the national average for all districts. Whereas Mizoram, Nagaland, Punjab, Tamil Nadu bring the average down. So wasting is also similar story. Gujarat, Jharkhand, etc. Are higher than the national average. So what we looked at is nutrition intake, the composition of the food, the only variable which influences the health of under 5 children particularly. The data had a lot to tell us, although we were not really surprised by the outcomes. So here we look at underweight in less than 5-year-old children, and a statistical model that we ran showed us that 3 variables were popped out as very significant other than nutrition intake in this age group. One was literacy amongst women. So this is women who are adult 15 to 49 and their literacy rate. So if literacy rate was improved, the underweight prevalence was lower in the community. That's what NFHS data showed us. Another variable which was important was sanitation. If the households having improved sanitation facilities were more, then the underweight in that community was lower. Another variable was anemia, which was significant. The children who were weaned at the right age were children who were had low prevalence. Also, that community had lower underweight. So all this, the models were quite good, robust models. They were explaining nearly 80% of the variation in the underweight prevalence. So the other models that we ran also showed us similar results, that if we improve the literacy amongst adult women by 10%, the stunting would come down by 2%. If we improve the dietary intake of children by 10%, the prevalence of underweight in that community would come down by close to 1%. Similarly, drinking water improvement, prevalence of more households with clean, improved drinking water would bring stunting down by 1%. So those there are many other ways that we can influence underweight or stunting or wasting in the children because of these other factors having a role to play in our community. Another factor that we looked at was agroclimatic vulnerability. Some of you may be familiar with the NICRA index. It's an index created by the agricultural community in India, where they've determined the vulnerability of agricultural to climate change. So they've integrated lots of variables which are related to temperature, humidity, soil porosity, water table, population density, etc., and created an index which groups all our rural districts from very low vulnerability to very high vulnerability. And as you can see, Gujarat, Rajasthan show very high vulnerability, the orange districts. And when we took the other piece of information from the National Family Health Survey, and we had underweight amongst young children as our indicator of health. And we tried to overlay the two data sets, and our objective was to find out districts which could be targeted. So where should the resources be first allocated? Can we prioritize districts in some scientific fashion? So as you see, this the data here is underweight children, and some of the districts that had earlier also pointed out are in Madhya Pradesh, Gujarat, Bihar, Jharkhand, and Odisha, which have the highest load of underweight population amongst children. And when we overlaid the two pieces of information, one coming from the agricultural sector, the NICRA index, and the other piece of information coming from the National Family Health Survey data sets, we found there were close to around 160 districts which could be identified as very high on both scores. They were highly vulnerable to agriculture because of climate change, and they had high underweight also. So this indexing showed us that there were districts these districts are all clustered in Gujarat, Rajasthan, Maharashtra, Madhya Pradesh, Uttar Pradesh, Bihar, Jharkhand, and Karnataka. So their current status is poor vis-a-vis nutrition status, and what the climate change influences show on agriculture, even in those factors, the whole community is vulnerable. So our objective here was to identify states or districts which should be targeted first or as a priority. Then we looked at spatial distribution of nutrition status. Again, we were exploring the National Family Health Survey, and we found that in the adult population, the anemia was not uniform across states or across districts. There was a larger burden in states of Chhattisgarh, Odisha, parts of Andhra Pradesh, parts of Gujarat, and several districts of Bihar and Jharkhand. If we looked at low body mass index, that again follows the same picture nearly as the underweight amongst children. And the scores were as high as 30% to 50% of adult women in the red districts have low body mass index. However, we also have the concern and rising trend of obesity in the population. States of Andhra Pradesh, Tamil Nadu, Kerala, parts of Maharashtra, Punjab show high prevalence of obesity already. The red districts have prevalence of over 25% to nearly 47% or 50%. So that's another emerging concern for the nutrition community in India. Having discussed the determinants of nutrition, one key component is how much are the people consuming. So for this exercise, we had a thought that maybe the country can be grouped into agroclimatic zones based on the Planning Commission agroclimatic categories, and seeing if there is a pattern which emerges based on the agroclimatic region where the community comes from. What the indicator that we were looking at was percentage of recommended dietary allowances that the population consumed. Here I'll project data only for high income groups and the low income groups of these districts. And the districts are, like I said, are grouped in by agroclimatic zones. So what we saw, there was some good news. Nearly all the people in the high income groups met their RDAs, the recommended dietary allowances, and they exceeded the recommended dietary allowances across all regions. That was a good piece of news. When we looked at the low income groups, however, the consumption of food to the recommended dietary allowance dropped significantly. The consumptions ranged from 64% to 84% for energy, for calorie levels that are recommended by ICMR. If we looked at the protein intake amongst high income group, the consumption was fairly good. People were meeting their recommended dietary allowances across all regions, across all the agroclimatic zones. However, when we came to protein, the consumption dropped, and it dropped significantly. So if there are people in the low-income groups, they could be consuming as low as 60 to 70% to 80% of their recommended allowances. And some of the regions were lower than others. West Coast, East Himalayan region, Gujarat Plains had lower consumption patterns. The scenario changed a little more significantly for vitamin consumption. We looked at vitamin A as an indicator amongst the high income groups. Even the high income groups had 50% on an average, you could say, of the recommended dietary allowances they could meet. The West Plateau had close to 47%. The Gangetic Plains showed higher levels of vitamin A consumption. But you would now be surprised. The results are showing up. The low-income groups showed significantly lower vitamin A consumption. The larger sources of vitamin A are fruits, fresh fruits, vegetables, and only 16 to 20% was met by most of the regions. Trans-Gangetic Plains had the highest, around 30% of their RDAs were met by the food they were consuming. But West Coast Plains, Eastern Plateau, Western Plateaus had around less than 20% of their recommended allowances for vitamin A was met. So next is the iron component of the diet that we assessed, and you would not be surprised now that only 40% or even less was consumed, the nutrient intake was consumed by the people for Eastern Himalayan regions, West Coast Plains and Eastern Coast Plains. However, there were areas and regions which were much better than this for iron. And this is only the low income groups that I've shown here. So based on our observations, the data that we explored and our discussions with experts, we've identified a few strategies that could be worth piloting in the country. One is expanding the PDS or the midday meal schemes and the public distribution systems to include locally cultivated grains, pulses, legumes, or cereals, such as millet, sorghum, and as they are uniquely high in not just proteins, but also calcium and iron. Incentivizing production of locally grown micronutrient-rich food. It could be agri-produce or aqua-produce. So green leafy vegetables and mangoes, fish, if they can be promoted, incentivized somehow. For this, and one way could be improving the food supply chains, including cold storage places in rural areas, so the off-season availability of micronutrient-rich produce is higher and better and at more affordable rates. Other ways could be increasing shelf life of the food through different mechanisms. One could be solar dehydrators. Introducing food processing units in the rural areas, introducing micronutrient-rich processing centers in the rural communities. That would enhance the livelihood opportunities also. Also is required increased awareness in different food preparation methods. So we are used to many ways. Traditionally, Indian preparation methods had richer ways of producing, consuming food, and that could enhance the nutritive value of the food. And these food preparation methods could be tried even in government schemes. Other popular ways could be improving cultivation, increasing cultivation of biofortified nutrient-rich produce, such as corn, rice, banana produce, which is affordable and accessible to different sections of the community. And of course, partnership with other sectors is equally important, addressing the sanitation and hygiene concerns of the community, availability of clean drinking water, are other factors that could influence. So with that, I'll conclude my presentation, and I'm open to questions now or later towards the end of all the presentations. Thank you. Pooja ma'am, over to you.
Yeah, thank you, Ms. Sehgal. Hope to take the questions later in the question answer session. And thank you so much, Ms. Sehgal, for enlightening us with the data, which definitely be very, very useful for designing programs and, coming up with micro level implementation effectively. Thank you so much. Thank you. Now our third panelist is Dr. Lakshmaya, Head Public Health, National Institute of Nutrition. Dr. Lakshmaya is an epidemiologist and public health nutrition specialist in the Division of Community Studies. Trained in medicine and public health, he has been researching extensively in the area of public health nutrition. He is the execution in charge for the activities of the National Nutrition and Monitoring Bureau. Dr. Lakshmaya will give his perspective on nutritional challenges, both the urban rich and the urban poor. Dr. Lakshmaya, over to you for the presentation.
Delighted to speak with very dignitaries available in this today. So especially Sri C.K. Mishra ji, then Ajay Mathur ji, and Dr. Ranjan Shankar ji, and Alok Ranjan, then Purnima Menon. So many experts are there. Really, I was thrilled by sharing this dais with these people, and I am also thankful for TERI for inviting me to speak on its nutrition challenges and other things. So as you know, the human life requires 51 essential nutrients, and these are all nutrients are very essential. And even before we saying this, the nutrition and health we cannot separate, because nutrition leads to health and health leads to nutrition. Even World Bank and other WHO, UNICEF already said that nutrition is a center for overall development. So therefore the food consumption is very, very important, and many diseases, many nutritional deficiencies is the main reason is inadequate intake of food. So as we already discussed several speakers about the problem of malnutrition globally and especially in India. So the global challenges are, you can see it is a 2 billion population suffering from micronutrients like iron, vitamin A, and 150 million children are stunted. And the important of this is almost 1/3 of children are contributed by India itself in this stunted children. So the 52 children wasted, and adults overweight obesity more than 2 billion, and 41 children are overweight obesity, and even 88% of countries suffering from one or the two problems. And suppose if you come to the India, so we are facing triple burden of disease, and even previous speakers also discussed all these problems. You can see then one is the first start, protein energy malnutrition, micronutrient deficiencies, diet related non-communicable diseases, and in the diet related non-communicable, especially overweight obesity, insulin resistant, type 2 diabetes, cardiovascular disease, cancers, and etc. So recently the CNNS survey carried out among children, this also gave very good insight about the nutritional problems. The stunting is 46 million children are suffering, and 72 million diabetes, and 166 million overweight obesity. And the anemia is a great, a very big problem, because it is a micronutrient deficiency. One of the micronutrient deficiency, every 2 persons, 1 person is suffering from anemia, whether it any age group or any physiological group, the anemia prevalence is very, very high. So then we have recently analyzed this NFHS data and NNMB data, and you can see the stunting, the frequency of stunting, and the number of states in India. You can see almost 40% stunting with 6 states are there, and less than 20% stunting is only 1 state. And so actually we should all states should manage or control up to less than 20 stunting prevalence, and that will take a lot of time, and as per even SDG goals also we have to achieve. And even Poshan Abhiyaan also is a they have set a goals saying that every year at least 2% of stunting should be reduced in the next 3 years and by 2022. But at the present reduction, it is it may not be possible until unless you take a special steps and a special care. So the wasting also, you can see the several states are more than 15 states suffering from more than 20% of wasting. And what are the determinants? Determinants already even this Meena Shegal and other even Alok Ranjan, they have briefed very excellent, and you can see. So the nutrition is I already said that it is a main reason is food consumption and also health. So this the determinants are several determinants. That's why the malnutrition is a multifactorial in nature. So these are all the factors we have to act. That's what the convergence, even government of India and especially some honorable or Prime Minister initiated and launched the Poshan Abhiyaan, and one of the pillar in the Poshan Abhiyaan, out of 4 pillars, one of the pillar is convergence. So convergence is very, very important, because health and nutrition is very important, but nutrition is a multi-sectoral problem. So in the plan document, in the policy document also, they have documented, they have included some 13 to 15 sectors are involved in the nutrition. And in that, they categorized into primary stakeholder and secondary stakeholders. And mainly primary stakeholders are 6 stakeholders. One is health, education, social welfare, DWCD, then agriculture, especially horticulture. So even water and sanitation, WASH. These are the primary stakeholders to improve the nutrition. So the determinants are, you can see the determinants of nutritional status is, that's why I told multifactorial. You can see it also influences the agroclimatic factors, and Dr. Shegal also presented agroclimatic region wise what is the problems are there, and then demography factors, socioeconomic factor, disasters and emergencies, and so that will affect the definitely household food security, and physiological factor, pregnancy, lactation, and breastfeeding practices, IVC practices, and availability of different government supplementation programs and other income generating programs also influence the purchasing power, and the socio-cultural factors. And Dr. Sri Mishra ji explained what is the socio-cultural, very well explained and briefed about socio-cultural influence in food intake and food practices and behaviors. So then these are all leads to nutritional status, and of course environmental factors also very important, that is WASH program, personalizing safe drinking water, and pathological conditions, and this especially the role of the health and healthcare issues also very important. So the many different factors shape the nutrition situation of households and individuals, and food availability and access to food and health education have the major impact on nutrition. And social and gender relations and environmental conditions, infrastructure, the local economy, the political situation also affect the people's nutrition. So these factors interact in variety of ways depending on the context and livelihoods of the households. And because of the factors affecting nutrition are multiple and diverse in nature, and address this malnutrition needs to be a multi-sectorial and integrated. So this requires a joint action by all the groups and all the multi-sector departments. And Poshan Abhiyaan, I already said the Poshan Abhiyaan is a multi-sectoral approach, that 4 pillars are there. One of the pillar is multi-sectoral approach. And because I have been working more than 25 years in the nutrition field, and I have several areas and several districts and states we have visited, and but the convergence is very less. Even 20 years we are speaking about convergence, and the convergence is never happened. And sometimes convergence is there in top level, but convergence also there in the lower level, but convergence is absent in the middle level. So the middle level is convergence is very, very important, and lower level, that ASHA worker, Anganwadi worker, and other grassroots level workers and grassroots level functionaries, there is a convergence. But we want every level the convergence is very important, then only we can achieve the desired goals. So the food security and livelihoods is very important. I already given the list of factors. So number of household food, so the household food production important, and few opportunity for stable employment, high food prices, low and irregular incomes, high dependency on market foods, reduced number of meals, low purchasing power, high consumption and cheap unhealthy street foods. All these factors influence on food security. And healthcare facilities, so limited income to buy safe water and hygiene, and limited knowledge of nutrition, poor hygiene practices, poor infant and feeding practices, and water and health environment are important. So these are different levels also we have to take at a pre-pregnancy period, pregnancy period, at birth, and post-pregnancy. So the pregnancy period is the main reason for intergenerational cycle, and the birth weight of the child, spacing of the child, and age at marriage of the women. These are all factors influence, and other service indicators like early registration of pregnancy and regular antenatal checkups, iron folic acid supplementation, institutional deliveries and post pregnancy factors we have to take care. But several programs are there to cater every level of this thing, and the program implementation and performance. That is, these are the very important. The coverage, and Dr. Sri Mishra also said that if just improving the coverage is not enough, the quality of services and quality of inputs going into the people, the beneficiaries, that is more important, and involving the Anganwadi workers and other people. Okay, so then supply chain and management linked to ICDS, several things, supply chain linked to ICDS. ICD is the main, it is a window of the at village level, and all services are integrated at ICDS level for maternal nutrition and child nutrition. So undernutrition continues to be a wide problem in India. The central and state governments implementing number of specific intervention programs, but there is a need to revise these programs time to time for its achieving its desired goals. So far, the revision has been taking place with the utilization of anemic data by until 2016. But currently, NNMB state units, including NNMB Central Reference Laboratory, were closed by 31st 2015 by Ministry of Finance due to some administrative reasons. But there is no, we are not collecting dietary data now. So this dietary data, 16 state units were there, NNMB, and we used to collect rural diets and urban diets and tribal diets. So monitoring of nutrition and health status of various population groups time to time is very essential. It should be dynamic in nature to enable the planners, implementers, developmental planners to use and revise existing or design new health and nutrition intervention programs. So therefore, there is a need to conduct a pan-India study, mapping of dietary pattern and comprehensive health status, at least at state level estimations, by overcoming gaps identified in the NNMB surveys. So the NNMB diet and nutrition surveys were limited to only 16 states and delay in the release of final reports due to manual data entry. To overcome all these gaps, a online survey and the pan-India study is needed. And we have evaluated and we have analyzed some of the data what India eats based on NNMB data. And my plate, we have devised, NAN is devised my plate, and what are the foodstuffs should be there. It is a multi-grain and vegetables, fruits and cereals. So what is the proportion should be there to give a optimal and healthy diet. So, and we have also compared, this is the my plate nutrition composition and other information is given in this slide, but because of the limitation of time, I may not explain all these things, but this as per the my plate, the energy levels, the cereals, millets and different food groups quantitative table is given here. And what are the key highlights in the my plate? So we have NNMB data analyzed what is the intake of this thing. The report presents for the first time the contribution of various food groups to the total energy and proteins and fats and carbohydrates. So the healthy diet concept, because now we are facing a epidemic of non-communicable diseases, high diabetes, hypertension and other cardiovascular diseases. For that, so the healthy diet, how should be the healthy diet? The energy should distributed, the energy should come from carbohydrates 50 to 60%, 50 to 60%, and protein it should be 12 to 15%, and fats it should be less than 30%. So that is the ideal way of getting energy with the three proximal nutrients. So the proportion of population consuming more than recommended. So the consume more than recommended intakes of cereals was 97% in rural and 70% in urban region. Proportion of population consuming recommended food groups is less than 66% protein from pulses, legumes, nuts, milk, flesh foods. As a good source for protein were only 5% among rural and 18% among urban population. So there is a lot of grossly deficient of quality food consumption among the population groups. So low consumption of fruits and vegetables and low intake of milk and milk products increase the risk of diabetes and hypertension respectively. Okay, so we have several programs are available, nutrition specific programs, more than dozen programs are available in India, but their objectives and goals are very well set, and the program is good, but the inputs wise also it is good, but only thing is we are failing at implementation and monitoring. So that monitoring and implementation is very, very important to things. So now we know the problems of nutrition and we know the methods of prevention and control malnutrition, and we have sufficient nutrition intervention programs, and we have manpower to do all these things, but it is the time to have independent monitoring and evaluation of health and nutrition programs, and to give a continuous feedback and mid-course corrections in order to provide a significant role and improvement in the nutrition status of the population. So this is my concluding points. Thank you for giving this opportunity.
Thank you so much, Dr. Lakshmaya, for giving us the perspective on the challenges, also the requirements, and highlighting the need for concurrent evaluation for the mapping the nutrition and the adequacy. Thank you so much. We have our next speaker, Dr. Ranjan Sankar, Director, the India Nutrition Initiative, Tata Trust. Dr. Sankar is a physician and served in Army Medical Corps for 25 years and retired as Senior Advisor Medicine. He has worked with IDRC Canada as a Regional Technical Advisor, with GAIN as a Regional Representative for South Asia, and is now Director, the Indian Nutrition Initiatives, a nutrition initiative of Tata Trust. Dr. Sankar is, his perspective will be on food fortification, a complementary strategy for prevention and control of micronutrient deficiency. So we look forward to. Over to you, Dr. Sankar.
Hello? It's not audible.
Sir, you are audible now.
Hello.
Sir, you are audible now.
Okay. So you couldn't hear in the beginning. Should I start again?
Yes, sir. Earlier we couldn't hear.
Oh, I'm sorry. So good evening. Thank you, Pooja Gupta, and respected Sri C.K. Mishra, sir, Dr. Ajay Mathur, other esteemed panelists and friends. Thank you very much for giving me this opportunity to just share with you my thoughts on food fortification. I selected the topic as to position food fortification as a complementary strategy for the prevention and control of micronutrient deficiencies. Dr. Lakshmaya before me and also Dr. Sehgal referred to the global challenge of malnutrition. You know, there was a time when we said malnutrition, often it referred to undernutrition, but now we realize there are multiple dimensions. One is undernutrition, and we heard how this overnutrition, obesity, and overweight are increasing even in our population. And then a form of undernutrition or deficiency state that straddles both this under and overnutrition is deficiency of micronutrients. So many speakers and even Dr. C.K. Mishra referred to this as a major, numerically the biggest nutritional problem affecting nearly 2 billion people around the globe. Now, what are micronutrients? Micronutrients are just simple vitamins and minerals. There are several of them, but most of them, the point to remember is most of them cannot be made in the body and they have to be part of the diet that we take. Micronutrient deficiency is actually a quiet hunger. That's why it is called the hidden hunger, because it is largely a hidden public health problem. Unlike the gnawing hunger that results from going without food, the hunger of micronutrient malnutrition often goes unnoticed, even by those affected by it. Some of these micronutrients require our attention urgently. They are iodine, iron, vitamin A, and to this list we added zinc and folate or folic acid. The reason is firstly that they are the ones that are most often found to be deficient in people's diet. Secondly, their deficiency states leads to serious consequences, both as health consequences as well as socioeconomic consequences. And most importantly, there are strategies that are available to prevent and control their deficiency states, and most of these strategies are compatible with primary health care approach. Now, India has micronutrient deficiencies pretty widespread, and it's a major public health problem. And it was very clearly shown by Dr. Lakshmaya, and also Dr. Sehgal showed clearly the deficiency that exists through the diet. I won't go into it. There are anemia levels, as was mentioned earlier. Children, women of reproductive age, pregnant lactating women, more than half of them have anemia. Vitamin D deficiency, there was a time when we thought that in a country with so much of sunlight, there should not be vitamin D deficiency. But then when we started looking at it, you found that it exists almost everywhere. In any group that you looked at, whether it is rural, it is urban, whether it is in children or the elderly, the pregnant women, in all the age groups where you start looking at it, you find it. In fact, about 15 years ago, when it was first published from army soldiers with adequate exposure to sunlight, even in them, there was widespread vitamin D deficiency. Vitamin A deficiency, again, has come down substantially with the massive dose vitamin A supplementation, but subclinical vitamin A deficiency is still highly prevalent. The other one, neural tube defects. India has one of the highest reported incidence of neural tube defects, and we know nearly 50% of them is attributed to to folic acid deficiency in the periconception stage. I won't talk about the dietary diversity. It was very clearly shown by the previous speakers that it is low. And now, what is the solution? How do you overcome vitamin mineral deficiency? The ideal would be to diversify the diet. And it becomes a part of any strategy to diversify diet as much as is possible with whatever is available and affordable. Dietary diversification is a part of any strategy to look at micronutrient deficiencies. The next is you provide supplements to target groups that have high deficiency or high requirement of that vitamin and mineral, like we provide IFA supplements to pregnant women and young children. This requires a platform, this requires a delivery mechanism to do. The third one is to add the missing vitamin and mineral to a commonly eaten food. This is what is called food fortification. Food fortification, but it's important to realize that these strategies are not exclusive of one another. Often, in many contexts, you would read more than one strategy to control vitamin mineral deficiencies. Food fortification is increasingly being recognized as a good complementary strategy. It is cost effective. It has been practiced for over a century in the industrialized world. And in countries like India, it is grossly underutilized. So it has its place, but we must also realize it has its own huge limitations. Now, what are the types of fortification? WHO came out with a very useful guideline for member countries in 2008 as it classifies fortification as 4 broad categories. Mass fortification is generally the fortification of staple foods like salt, fats and oils, wheat flour, rice, and milk. Mass fortification is one which is often instigated and closely regulated and monitored by the governments, the public health authorities, whenever there is widespread deficiency in the population. Targeted fortification is like you target it to specific age groups, like micronutrient powders to children, or micronutrient powders even for women. Or in our situation, the supplementary food program of ICDS that can be fortified and provided. Then we have market-driven fortification, which is more like what is done by the industry. Often it doesn't reach the people who are most at risk. And also, it is not done at a level where alone by itself, it's unlikely to make a significant impact, but it can certainly contribute to increasing an incremental intake of a given nutrient. There are other types of fortification. Now, food fortification is not a new idea in India. As early as 1953, the country mandated fortification of vanaspati or hydrogenated oil. And then salt iodization started as an experiment in the Kangra Valley in 1954. And then 1962, the country launched its national goiter control program. And then, in the next after a few decades, it has been mandatory since the mid-90s. And food fortification is positioned in a lot of our policy documents as a clear complementary strategy. The National Nutrition Strategy, it has a mention, and successive 5-year plans, 9, 11, 12 plans, have specific reference and a clear mention of how to use food fortification as a complementary strategy. The most recent Nourishing India report, that is the backbone of our National Nutrition Mission, again recommends food fortification as an important strategy. If that were so, despite the early start, why is it that food fortification continues to be a grossly underutilized strategy in India? It is because we did not have the standards defined for fortification of staples such as edible oil, milk, or rice. And even what was existing for wheat flour was not consistent with either the WHO or the Codex recommendation. There is no one agency responsible. It was falling between the Ministry of Health and WCD, and also it was lost between the shift from the PFA regime to FSSAI. And more important to realize, there has been a wild opposition from activists and sections of scientific community, I would say, because often it is equated with packaged food or processed food. It is also thought of as, the moment we talk of fortification, it is just processed food, and multinational and big businesses would take over the nutrition agenda, and many such vague arguments that were put forth. But the point that the government in the last few years that has been uh, giving a great momentum to food fortification has focused more on what I said as mass fortification or fortifying the staple foods. Since 2007, there has been great momentum in bringing food fortification to the fore. The Global Alliance for Improved Nutrition started large-scale food fortification programs in India, the state of Rajasthan and Madhya Pradesh. Following that, in 2015, there is a Future Fortified Global Summit in Arusha. This again was led by Global Alliance for Improved Nutrition. There is a fairly big delegation from India. There are more than 10 senior bureaucrats attended this. Following that, many of them came back convinced what was happening around the globe, and a series of meetings were held, and that led to the Ministry of Health recommending to FSSAI to come up with standards, and standards for staple foods were promulgated. The FSSAI also came out with a plus F logo for fortified food, and a food fortification resource center is set up within FSSAI, and that is ably supported by many development partners that has helped scale up rapidly staple food fortification. Where are we now? When you take staple foods, iodized salt is the most successful public health program in India. Today, we have 93% of the households use salt with some iodine. In 83% of the households, the iodized salt conforms to the standard. This indeed is a huge success, considering the fact that there are more than 10,000 primary salt producers, and it's quite a fragmented industry. But still, we've been able to achieve this. Now, if you take the other two staples that have really scaled up in the last 4 years are edible oil and milk. Today, both are voluntary. Edible oil today, it's actually a edible oil industry is fairly consolidated. You know, there are about 65 to 70% of the edible oil comes under organized sector today, and also 65% of our edible oil is imported. You know, it's only 35 to 40% is local oil seeds and local oil. So of all the edible oil that is sold in consumer packs, that is anything that is in pack and less than 15 kg, 50% of it is already voluntarily fortified with vitamin A and D. If you go by just the per capita consumption and the total quantity that is consumed, we arrive at a figure that it reaches more than 700 million people every day. And this number would go up further. Milk, again, is only 30% of all the liquid milk that is produced and used is fortifiable. That is, the rest of it is not going through an organized sector or going through any processing. So only 30% of the whole is fortifiable. In that, about 60%, the 50% is already fortified. Probably it will also go up. But if you take the case of wheat flour, it is just not moving. It's a very small coverage. And rice fortification has got a fillip with the government of India providing some support and doing in about 15 states, large pilots. Now, why is it so? Why are we not able to move quickly, though we realize it's a high need and there have been very successful programs around the globe? But why are we not able to scale it up fast? That is one of the important challenges, is that choosing the right vehicle. And it also matters on what is the industry structure, whether it has to be voluntary or whether it has to be mandatory, and how do we really build the public-private partnership and alliances to support this. The choosing, when we take what is critically important for success of a staple food fortification is the more consolidated an industry is, it's easier to do. Whereas in our country, if you take wheat flour, I'll just show you in the next slide. Now, if you take oil, look at oil, as I said, there is tremendous industry consolidation here. The top 10 players have more than 35% of the market share. If you take the organized industry, it has more than 65% of the market share. And it is easy at this level. Technologically, they are, the refineries or extraction units are so advanced. Adding vitamin and mineral, vitamin A and D premix to that is very simple. And also cost-wise, it costs a very small proportion of their sale price. It costs less than 15 paisa per liter of edible oil to be fortified. Milk, again, it is the same. Wherever the fortifiable milk can easily be fortified, though it's only 30%. But if you take wheat flour, it is less than 15% of all the wheat grain that is consumed at household goes through organized sector. The rest of it goes through small stone grinding chakis, where technically it is possible to do, but then practically it's such a big problem in terms of reaching the premix to them or diluting the premix and provide. The cost will go up. Quality control is an issue, and so it's just not going. Rice, we have great ambition, but rice again is pretty large, and we have thousands and thousands of rice mills, and the rice fortification, as we want to scale it up, it has got to be done only during 4 months, because the rice after harvest within 2 months, it is all milled and stored. So the capacity to do such large quantities have to be created. We are now working on how to pair it over 12 months. It doesn't happen that way. So we have an interesting pilots going. We'll have to see how this can be scaled up. But in that situation, what do we really do? If the problem is so severe, we know that micronutrients are important, not that like what we considered earlier, that you first satisfy the people's calorie requirement and then you can look at micronutrients. That's not the view. The micronutrient deficiencies by themselves contribute substantially to global burden of disease. And how can we target those who need it most? We have these excellent programs, ICDS, the school feeding program, public distribution, the PDS. We need to see how to make the food aid programs fortified. And this can be done focused, and this will also target the most vulnerable. In ICDS, we have this take-home ration, which need to be, a lot of thinking has to go in to make this a most suitable supplement to children and women. And that should be fortified. Even the hot cooked meal provided in ICDS and school feeding, we can give fortification inputs and make that reach the women and children. On the same vein, we also know that targeted fortification, like multiple micronutrient powders, are important. Now, these things require a lot of attention and our focus and pushing as much as we want to do the staple food fortification, because the children between 6 months and 24 months, the requirement of micronutrients, particularly iron and zinc, is very high. And we also know that between 6 months and 1 year, it's very difficult to achieve by dietary diversification alone, along with breast milk, the level of iron and zinc requirement. So it is best that they are added from outside. In situations where complementary foods are made at home, and rightly so, then adding vitamin and mineral premix to the food that is given at home as a form of micronutrient powders can help very much. And this is an intervention that is very well tested. It is being done in several countries. And India is the largest manufacturer of micronutrient powders, but it hardly uses it in its own programs. Now, I would just say that food fortification is a good complementary strategy. If well designed and properly implemented, the various options for food fortification can contribute to improving public health outcomes. It is one aspect, the fundamental in the base of the pyramid, in the implementation pyramid. We have done it. We have already brought out the standards. There's a lot of directives from the government, but we need to take a lot of care in implementing it. Just to say, globally, there are 140 countries that have legislative support for salt iodization. 85 countries mandate at least one kind of cereal food fortification, and 40 countries that have mandated fortification of edible oil. So it's something which is a global practice. We need to adapt and do this, understanding the limitations of this and closely following up. That is why it cannot be a standalone intervention. It rather need to be seen as a complement. As I said here, if we need to, as large-scale fortification is a population-based intervention, we need to really take that forward to also, along with targeted intervention, and it should be part of the integrated programs. Only then we will be able to achieve, impact and significant reduction in vitamin and mineral deficiency. I'll stop here and thank you very much, sir.
Thank you, Dr. Sankar, for giving perspective on and instilling hope by proper planning, designing, and implementing for food fortification, which may definitely go a long way in solving and addressing the issue that we are deliberating on. Thank you so much. We have now the next speaker, Dr. Purnima Menon, Senior Research Fellow, International Food Policy Research Institute. Dr. Menon is the theme leader for South Asia Nutrition Program in IFPRI's Poverty, Health and Nutrition Division. In her work in India, Dr. Menon directs Poshan, Partnership and Opportunities to Strengthen and Harmonize Action for Nutrition in India, an initiative to support more use of evidence for nutrition in India. She conducts implementation research on scaling up maternal and child nutrition interventions, including on evaluating large-scale behavior change. Looking forward to have your deliberations on behavior change for better nutrition status, opportunities, and challenges. Dr. Purnima Menon, over to you.
Thank you. Thank you so much. So initially, I thought I would speak a little bit about my research on behavior change, and then as I heard us sort of discussing and heard the other speakers, I thought I needed to take a slightly different tack and speak to the idea of coming together. So it does involve a lot of behavior change, but I think we have to ask whose behavior do we need to change to be able to achieve India's nutrition goals. So before I sort of get into the rest of my talk, I want to remind us that we, the nutrition policy community, including all of us, the eminent panelists in this room, and the many, many, many hundreds of people out there who work on nutrition day in and day out, or who work on other issues addressing nutrition day on and day out, have really come together in the last several years, maybe even the last couple of decades. So I'm really pleased, that I can be here today with all of you as well, because I think one of our big challenges in nutrition is to bring more and more and more people together under the big nutrition tent, because we know that change will take so many of us. So I was involved in part of India's nutrition journey together with the other stalwarts in the room over here and many others As the pandemic hit, and we started to realize that there was a real chance of the derailing of nutrition progress in India, we all came back together again, in a sense, to reiterate our commitments. And together with the Coalition for Nutrition Security in India, we launched that document that you see on the right, which is a commitment to action. It's not a call to action. It recognizes that all of us have work to do here. And it has been signed and endorsed by over 200 people so far across India, and it sort of commits to 6 different things. Sustaining leadership for food and nutrition security in all spaces. I'm really pleased to have TERI and FOLU also involved in this. I'm so pleased to see you as well. Dr. C.K. Mishra, your leadership on health has been exemplary, and I'm just really excited to hear you also bring the power of your words and your commitment to nutrition. We also talk about scaling up interventions within ICDS and health, committing to work on ensuring adequacy of financing for nutrition, of addressing underlying challenges such as food insecurity, hunger, gender issues and sanitation issues, strengthening the use of data and evidence, and finally bringing it all together and strengthening systems. But in all of this, I think, while we recognize the power in a policy community coming together, I think our biggest task remains bringing it together for those who matter, which is the millions of mothers and babies in those first 1,000 days in particular, who are born every year in India. We've learned a lot in the last 1 decade about what has helped to reduce stunting in India. So I don't talk about stunting in India anymore as a puzzle. I think we talked about stunting in India as a bit of a puzzle maybe 10 or 15 years ago. We don't do that anymore. We don't talk about it as a stubborn challenge, because in fact, we have seen remarkable change across many different states in India. My research colleagues have studied 4 nutrition success cases in the context of India. These are successes that occurred over a period of more than a decade. And they reiterate the multi-sectoral nature of nutrition. They reiterate the fact that we must make change happen in different domains to be able to change outcomes such as stunting. And they reiterate the importance not just of working on health and nutrition challenges. We found that health and nutrition interventions do contribute to about 1/4 of the change that is seen over time, but also that underlying household characteristics such as improvements in socioeconomic status and assets, and improvements in maternal conditions, education, age at marriage, access to care, so on and so forth, make a very big difference. What we've also shown is that states can be very dynamic in responding to major national policy efforts. One of the big drivers of change in these successful states was that they all responded substantially to national efforts, but they also innovated and added on beyond that. The other important piece is that all of the states that saw success in nutrition outcomes such as stunting did not forget that you need food for nutrition, or that people need money to respond to behavior change. All of them had a range of programs to address food security and poverty. And many of them actually also were states that were growing very well economically. Now, these are all things that have been hit quite substantially in this, in the context of the pandemic, which means that we have turned the clock behind a lot. But we've also learned that what supported policy change in all of these contexts was that there was a vision, there was a desire to achieve change. And in all of the states where change happened, there were capable bureaucrats who were put in charge of key programs and who were given time and space. In most of these states where change happened, bureaucrats, people who were leading big programs like the ICDS and health programs, were in their positions for a good 3 to 4 years. They were able to make change happen, to move the systems that Alok spoke about. And they were able to do this by working in partnership with a range of different actors in their states. Nobody was left out, nobody was ignored, people were not necessarily sidelined. They brought people together to solve difficult problems. So I think these offer us hope, and they offer us great optimism that change is possible, even in a country or in contexts that have been, or for problems that have been written off as being stubborn and unchanging. Now, what I take away from this is that it's really important that that the kinds of things that bring change reach those critical households in the first 1,000 days. I think we sit in a place where this has been recognized in policy. So, this slide that I'm sharing with you is a direct quote from the operational guidelines for Convergent Action Plan around Poshan Abhiyaan. It makes the goal of convergence very explicit in that the goal is not the ministry sitting around and talking to each other. It is not us sitting around and talking to each other, but that the goal of convergence is that services converge on the household. Ensuring that multiple services converge on a household is essential for reducing undernutrition in the country. It cannot get more explicit than that, right? That gives us a goal to say, well, how are we doing on that metric of convergence? Not whether ministries are coming together to meetings or whether district magistrates have held convergence meetings, but on how services actually converge on households. So if we're not keeping our eyes on that goal, we are unlikely to achieve progress, right? There are 13 schemes in 7 ministries listed in the operational guidelines for Poshan Abhiyaan. One of the things that our research team has done is kind of take a set of, and I'll show you the pictures in just a second for one district in Bihar, but take a set of indicators from available public data to say, can we assess the extent of convergence? Can we do that in geographies, in administrative geographies, to help people see how far they need to go to close gaps in convergence? So I'm going to show you just a couple more figures. Bear with me as a researcher here. And this is what you should see when you look at them. So if you see a figure that looks like what you see on the right side, which is that, that's a set of interventions that should be reaching and converging on a household. If they're reaching all households in the district, you will see the lines on the outside of that radar diagram. If they're not reaching all households in the district, you're likely to see something that looks like on the left side. So now I'm going to show you the results for what does that look like in one district in Bihar, okay? And I think, Dr. Shankar, this may be work that we did together with one of in the context of liaising with your Swasth Bharat Prerak's team. So this is what it looks like for pregnancy interventions in Bihar. So the blue lines are all the different districts in Bihar, and the red line is for Araria in Bihar. And what you see is that you're very far from convergence, even of a set of basic health, ICDS, and sanitation efforts and drinking water efforts in one district, all right? We are nowhere close to convergence. But if you don't know this, how can you achieve convergence as laid out in Poshan Abhiyaan's plan? Convergence is not about a meeting. It is about meeting to see how we can achieve this goal of convergence, which is everything reaching those 1,000-day households. So I want to argue that even just with the data that we have, with the definition that we have of convergence, we collectively can help move things forward by helping people see how far or how close you are, which interventions need action, and which ones you're actually doing quite well on. So what will it take to kind of pull this whole thing apart so that, those lines are around that circle, around that radar, and not clustered in the middle of it? So this is what it looks like in pregnancy in this one district. This is what it looks like in early childhood. You can see that there are some really critical gaps here, and some of these gaps are just on the very basics, the very basics that are already in our systems. So to me, the solutions to make convergence happen don't lie in new models of or new program models. They lie in using existing program models, but using data strategically to help us understand who is left out and from what interventions. This has been done very successfully. It has been done very successfully for things like immunization in India. There is no reason why this cannot be done. But we have to keep our eyes on the ball, that what's important here is the outcome. And we have to find ways to help us understand how to move on that path. And I think we are still struggling on that front because too much discussion or too much work on convergence remains about people gathering around a table. And it's not clear to me whether we are discussing how do the things that those people control reach every single 1,000-day household in their family, in their geographic or programmatic areas. The same applies for the food system. You know, I find it troubling, but also very interesting when people talk about single solutions. You know, when we say millets are the solution, or just eggs are the solution, or just something else is the solution. In reality, what we eat is so much more complex than that. All of us know it. We are human beings. We all eat the same way as people, whose lives we may be trying to improve. What we eat comes from different places. Different parts of the food system converge on the same geographies and the same individuals, and that shifts across the life course. These are photographs. I believe that photographs are very powerful. So these are photographs from a single district in Madhya Pradesh. And what you see here is exactly that. You see women picking up their rations. You see food coming to the family from the ICDF THR. You see a range of different foods, predominantly unhealthy foods, available even in some of those villages and districts like this. And then you see women gathered around discussing nutrition. Well, what is going to happen when people go back into their homes to make decisions, perhaps based on the information, is they're going to have to wrangle with the food that comes to them from all across their food system, and then make the choices that fit for their families. Every single one of us is doing that every single day. Poor families need to do the same thing and have more trouble making those decisions and trying to figure out how to connect the dots, right? How to make healthy meals happen with what comes into your home from all of these different sources, including your own local production. So I think we have to sort of really put ourselves in the same place as the other people that people seem to talk a lot about, and recognize that we are all human, and that the same principles here apply to all of us just as they do to poor people, and that it's even harder for poor people to put healthy foods on their table than it is for those of us who have all the resources in the world. We cannot ignore the fact that relentless food marketing is having a huge impact on people's diets. This is data from our own surveys on the left side, and then just a picture of another study from Nepal. The food industry and many of the unhealthy foods they produce, actually all the foods they produce, reach our homes and our tables, and they reach us very early in life. So these are children 6 to 23 months of age. They're under 2 years. Many of them have already consumed sugary snacks, have certainly eaten biscuits, have consumed salted snacks, even instant noodles, even tea, coffee, and sugar-sweetened beverages. So while we think about behavior change, I think we have to acknowledge that companies are reaching people in very powerful ways to shape their food behaviors, often in ways that we in the public health community absolutely don't always have the power to do. What we have learned in all of the behavior change work that we have done, have been studying behavior change programs in nutrition since, I think probably, since about 2002 now, so really a long time, is that I think it is easy for us to think only about the messages we promote, but in fact, what we have learned is that new behavior change messages integrate always into existing patterns of eating, and the extent to which people are able to integrate or not integrate different new behavior change messages is dependent on their own resource constraints. And I don't mean just money. Time and workload, especially for women, are a critical resource constraint in terms of nutrition. They also integrate into some of their aspirations. If poorer communities see richer communities using baby bottles, for example, that becomes aspirational within poorer communities. So I think we must be very open, even when we think about public health messaging and all of that, to recognize that it's always going to be a bit of a mix. And in the end, what we want to make sure somehow is that, a baby in the first 2 years, I estimate, is fed about 5,000 times by their parents or by their caregivers. How can we make sure that a majority of those 5,000 or so feeding episodes that happen multiple times a day, every single day in those 2 years of life, how can we make sure that a majority of them includes healthy foods? This is true for all of us, just as it is for babies, but the consequences for babies are much more dramatic. So I want to end, by saying that India's nutrition journey has been a long one, a positive one in my view. It has been shaped by multiple forces. Today, we as a nutrition policy community, and I say policy community, all of us, researchers, administrators, politicians, development partners, NGOs, academia, we have a much better understanding of the challenge, much more agreement on what needs to happen. So we have come together. I think we now need a really, truly intensive focus on bringing it together, helping to bring it together for the millions of households in the first 1,000 days to support good nutrition for them, for all of us, through that life course. So the goal of supporting 1,000 days of at least 5 to 10 optimal behaviors or feeding episodes every single day is no small challenge. It really, truly will take all of us. And I think, I was excited about this event because, I think this is a group that hasn't perhaps talked as much about nutrition. And so we're very glad to be here and to be here together with you and to share some of our insights. These are difficult times, and I think we need to be inspired, and we also need to be together, and talking with the same voice and working towards the same goals. And the second part, even more important, working towards the same goals. The last thing I want to say is that a few days ago, the Right to Food campaign released the findings of their Hunger Watch, and that just joins, in a sense, the plethora of data that is accumulating on how serious the challenge of assuring good nutrition is going to be because people's lives have been upended, because food insecurity exists. And so I think it's truly going to take all of us to figure out how to meet this big challenge for India. And we're going to have to work together. There is no other way to do that. This is no time to not be together, to not draw on the best that each set of partners has to offer to this challenge. So thank you again for having me. I hope you will see now that I talked about behaviors that cut across both us as a policy community, thinking about the behaviors we want to support families to achieve for themselves and their children. Thank you so much.
Thank you so much, Dr. Menon, for your insightful perspective and fully agreeing to that in every walks of life, we must consider household as a unit to be addressed, whether we are talking of sustainability or we are talking of nutrition status. And definitely, as you had suggested, the goal to be that support for 1,000 days, and that's no small change. And I remember Mother Teresa saying that let's not go for big things, let's do small things with love, with great love. So thank you so much. And with this presentation, I now open the forum for question answer session. And I would definitely like to seek your advice on that. I have few questions which are specifically addressed to each expert. Maybe I can go one by one so that our panelists may address, or if you feel so, then the entire panel can address the same questions. So I think, can we go with Dr. Menon since she's already here?
Sure. Should I look in the Q&A box, or would you like to read out the question?
I would read it out for you.
Sure.
What is going to be a likely trend? Can traditional grains such as millet be in the dietary habits of millennials? That is what the question has been posted.
Yeah. I'm not sure likely trend in what, but I mean, millets are already a food trend, interestingly. Millets are a great alternative to cereals, but I think, to me, there are no miracle foods in nutrition. I'm a trained nutritionist. I do not believe in miracle food. There are no miracle foods. There are only healthy patterns of eating that one has to sustain over a life course. And if we remain in search of miracle foods, as we remain in search of magic bullets, we will often be disappointed. So, I have no, I think it's fantastic to see a great interest in millets. I think they're an important component to diversify our, the cereal base of our diets, particularly in the context of emerging non-communicable diseases and, some micronutrient deficiencies. But they have to be combined with other efforts that bring diversity to our plates. A plate full of millets is not going to solve our nutrition problem because it's still going to be a plate full of one kind of food. What you want is a colorful plate. I really love the new NIN My Plate, visualization, because I think it does a great job of helping people see what an aspirational, nutritious plate looks like. And we have to aspire to that for every person here, not just for us. Thank you.
Thank you so much. Thank you, Dr. Purnima.
Can fortification of food be available across income groups? That's a question which has come for Dr. Sankar.
Could you just repeat? You said fortification across?
All groups.
Income groups.
All income groups.
Yeah.
Yeah, actually, as I said, food fortification has to be seen as one more strategy to increase the intake of essential vitamins and minerals, and that depends on the context, at what level we are, what are the other strategies that are possible, and how much of contribution a fortified food can make. And we have to really target the most vulnerable, and the vulnerable are all, fortunately, as all the data show, are the income poor and the lowest socioeconomic groups, and also geographical vulnerability. And they have to be reached. And the data that Meena Sehgal clearly showed, that you found that many of the people in the highest wealth quintile or ascetists probably diversifying their diet enough and consuming enough calories or more than what is required, and only in few vitamin A they were a little less, and iron they were a less. Whereas when you go to the low income households, the intake of vitamin minerals as well as the calorie gap was quite wide. So there's no question, whatever we do, we need to have look at it with the equity lens and really target. One of the unfortunate things with our universalized programs, it was required many years ago when things were far more widespread. There is so much widespread food insecurity. Now, I'm not saying it is gone, but it is getting more clustered around certain groups. It could be, one is economic factor, the other is geographical factor, the other is also certain social exclusions. So targeting for nutrition is important, and food fortification certainly is one more intervention that need to have this in the background. Thanks.
Thank you so much, sir. We have another question for Dr. Lakshmiya, saying that does tracking nutrition status more frequently likely to happen? Do we see the possibility of having more frequently having the nutrition status tracked? Dr. Lakshmiya?
Common application of software. Now all growth monitoring is taking place in the software. We can track nutrition status of children, especially for we can see the time trends and over a period of time. So that will guide us to what is the growth faltering, or if growth faltering is happening. And I already said one more thing, and that nutrition surveillance system. We have started a nutrition surveillance system in 6 states. on a pilot mode in 6 projects, and we are covering almost 1,000 Anganwadi centers. So we have distributed tabs, and we have also given internet connection, and their monthly monitoring is done through these tabs. And we have central servers, one server at each DWCD director or commissioner with DWCD, and central server is available in NIN. And we have also created QR code for each child. So just if you enter the QR code, and all data will appear, and every time also we need not repeat all ID particulars and everything. Automatically it is copied, and we can update the data. So that way we can do the some trends analysis, and we can see that whether nutrition status of that particular Anganwadi center or particular block or project area, whether it is improving nutritional status or not. And another additional thing also, there is some even risk factor also, some socio-economic and other this national nutrition programs also there, vitamin A supplementation, then IFA supplementation, immunization, everything we can track with this in this project. Thank you. Did I answer your question?
Thank you so much. Thank you. We are running short of time, but thank you, Dr. Alok Ranjan, for coming back to the forum. One question has been posted for you saying that in future, do we see the possibility of decentralizing the MDM approach further? Dr. Ranjan?
Yeah. So I think it would have been better to have a bit more detail in terms of what exactly is asked over here. But from what I understand, I'll go back to what Mishra sir said, that adolescence is very critical aspect of breaking this intergenerational cycle, and for that MDM is a key component as well. But MDM is more like, for, if you ask me as a public health and nutrition person, it's very much a tool which helps keeping girls in school. And if you are able to keep girls in school till the age of 18, that has much far-reaching impact. If you look at the whole Lancet framework, a lot of components over there, whether it's women empowerment or her decision-making capacity, her own economic empowerment and all, I think all those also help as well. But at the same point of time, fortification, as Dr. Shankar said, using a social safety net program like midday meal would be useful. In terms of the decentralization, I think I would like to understand a bit more in detail around the question, and not just recommend on anything on the decentralization without understanding what aspect do they want to ask on that.
Yeah, we can take this later, or maybe this can be clarified. Thank you so much.
Thanks.
We come to the end of the program, and we have Shri S. Vijay Kumar, Distinguished Fellow, TERI, Lead Food and Land Use Coalition, India, for giving us the concluding remarks and concluding the entire webinar for us. Shri Kumar was a member of the Indian Administrative Service, which staffs the senior position of India's bureaucracy at central and state levels. He has served as Permanent Secretary of India's Ministry of Rural Development, and Additional Secretary and Permanent Secretary, Ministry of Mines at TERI. He works on policy issues related to natural resources, including land, water, and minerals. He is also the lead of Food and Land Use Coalition India program. I invite you, sir, to offer the closing remarks and close the webinar. And I also invite CK Mishra, sir, for his closing comments. Thank you so much.
how do we go? Would you, should Mr. Mishra will make his closing remarks after my summary?
Sir, yeah, Dr. Mishra can be after you. And
Okay.
vote of thanks has to be proposed by.
Well,
I think
CK?
just go ahead and hear him because, sir, you will be taking care of the summary of the whole thing. So there's nothing really for me to add as such. So, sir, why don't you go ahead?
I would in fact suggest that maybe, you have heard all the panelists and you are the, you have been in the thick of things. Maybe you would like to sort of just give a few closing comments based on what you've heard and some of the insights that you saw just now, and what you think is very important, but it just needs that little bit of underlining given your your own experience and sort of insights having been there. So maybe you could sort of look at it from that, and then I will propose my vote of thanks.
Just two quick things. Nothing in detail really, because detailed presentations have been made. First is that we do, all of us, acknowledge that we have a problem. I mean, I think no solution can be found till you actually acknowledge that you have a problem. I mean, you can't be in denial. And we also realize that this problem has not been addressed perfectly in the way that it needed to be. So we need to change course. That is the second thing that I got. And to change course, there are two things that are coming up very clearly. One is in terms of convergence, which this country has been talking for so long, but not getting to. And the second element was a different strategy. And that is where our focus should lie. That is it merely micronutrients, a packaged food, a midday meal, a ICDS approach, or a PDS approach, which is going to work? Or do we need to broad base it based on local food and trying to see which food item in which geography of India is really going to work in terms of increasing nutrition? I think it's time that we give up a simplified medical formula to nutrition. But when I say give up medical formula to nutrition, please let us also remember that supplementary strategies like micronutrients, etc., will have to be done. And fortification of food, I do quite remember the debate in 2016 when everybody wanted to fortify food, but nobody knew how to go about it. And finally, we found a way out, and FSCI moved ahead with it. But even today, fortification is very limited. What the government is fortifying is very targeted to a very limited population. What the private sector is fortifying is actually not available to those who really need it. So we have to get to a strategy where access to the fortified food is increased. And we have to get to a strategy where food becomes the main thought process rather than add-ons and supplementaries. I think these were some of the takeaways that we had today. Of course, there will be geographical differences. Some states will continue to do better than the others. And I think, I mean, in a webinar like this, we are really not trying to find a solution to those problems. What we are trying to discuss today is that our present strategy, what is the new element that we need to add to it? And I think what came across was that we need to focus on local needs, local food, local habits, and see what nutrients we can give at the local level. Thank you, sir. Okay.
Well, thank you so much, Mr. Mishra. And I think you have hit the nail on the head in terms of, the need for nutritional strategies. We organize this seminar basically, in order to highlight the fact that we are currently in a situation where food security is still seen as a major issue, whereas, as Dr. Mathur also pointed out, that has largely been addressed, and today we need to move on and look at nutrition security. And I totally agree, and this is something we also will need to internalize when we look at strategies from FOLU's side, that nutrition is not only about the science of it, but also, the need to look at the cultural aspects of nutrition, as both on the problem side and also on the solution side. So I think this is something we will be we will be looking at. As Dr. Ranjan mentioned, that nutrition currently is a bit of an orphan, because partly it is seen from the health ministry side, partly it is seen from the women and child ministry side, partly it's even seen, from the rural ministries. But it is falling between the stools, and there is a need for convergence of policies, of strategies, of implementation. And I think Dr. Lakshmanaya perhaps mentioned that there's convergence at the top and at the bottom, but not in the middle, which is in no way contradictory to what perhaps Dr. Purnima Menon mentioned about the 13 schemes. The 13 schemes and the need to actually converge on the schemes on the household level. So the convergence of the implementing agencies is required at the middle, but the convergence has to take effect at the household level. So I think we are seeing some very important messages, and Mina's analysis based on spatial data actually gives very good clues on where the problems lie. And they're not only food related. The fact that women's literacy, sanitation, drinking water, clean cooking are all factors show that it is multidimensional, multi-sectoral. And I think Dr. Alok Ranjan's analogy of mopping the floor and closing the tap is very apt, but I think the person mopping the floor should continue to mop the floor, but you need another set of hands to close the tap simultaneously. I think that is the thing that really needs to be done. And I think all the panelists, the issue of fortification is important. I think, as you mentioned, and as Dr. Shankar mentioned, the mass fortification has certain problems. Targeted fortifications are partial solutions. How do we ensure that the fortification reaches those who need it the most? And how do we link it to ongoing programs such as PDS or ICDS? These are things that need to be seen. And I think all the panelists have addressed very important aspects of what is a complex and multidimensional issue, and we hope that in FOLU we will take due note of these and use it to fashion strategies that will help government and other policy forums to understand the issues better. So with these words, let me thank you all, one and all, for an really enlightening and fruitful discussion, and we hope that we will be able to organize perhaps another seminar on a related issue, and hope to have you back again. Thank you very much, and a very good night.
Thank you. Thank you for having us. Really nice to see all of you.
Thank you so much.
Yeah, let's stand up. Shankar sir, thank you.
Thank you. Thank you, everybody.
Thank you so much, sir.
Mishra sir, thanks, Ranjan sir. Thank you.
And thank you, Pooja, as well. Thank you for conducting the show.
My
Thanks,
pleasure,
Pooja
sir.
Appreciate Mishra sir coming to us when you were so busy with your movement of the house. Appreciate your.
It was a pleasure. Thank you.
Thank you.
See you. Thank
Good
you.
night.